So I'm grateful to the organizers and to AIOS sir for this opportunity. I'll be talking about ensuring good visual outcomes. I have no financial disclosures to make. So we all know that cataract surgery with eyelid implantation is the most commonly performed surgery and also the most successful. And not only we, but all the patients also know it. And so the patient's expectations, especially for spectacle independence and good functional vision, is very high these days. So while we still believe that a good quality surgery, a meticulous surgery, results in good quality outcomes, we'll now see that there are many factors which influence it. So as we saw with the previous talk, the quality journey starts with the first step. The first step in the quality journey is safety. So here it involves safety in biometry and safety during surgery, which are the key factors for a good visual outcome. And this is necessary at every step and every interaction with the patient. And the surgeon and the entire team has to ensure at all times, with the timeout being so sacrosanct, that he is dealing with the 4 C's: the correct patient, the correct eye, the correct procedure, the correct implant before starting the surgery and just before implantation. An excellent outcome in a wrong patient or a wrong eye has absolutely no meaning because the patient is going to be dissatisfied. Now the entire thing starts with a preoperative evaluation, where a thorough and structured preoperative evaluation is very essential for prognosticating the visual outcome, knowing whether the vision loss is only due to the cataract or if there's any other comorbid condition. And with this, we can clearly explain the visual prognosis to the patient so that the patient is not dissatisfied, and we take an informed consent for this. It also helps in recognizing the risk factors that could lead to the need of adjuvants like iris hooks, CTs, etc., or for additional procedures like vitrectomy. And these cataracts can also be classified based on these risks. So group 1 has no risks. They are good cases where complications are not expected. Group 2 are prone to complications like a shallow AC, brunescent, mature, hypermature cataracts, and with short axial length and long axial length. And group 3, where complications are a definite certainty, like a PC dehiscence with PPC or with a post-VR cataract, and also subluxated or traumatic cataracts, where vitrectomy is definitely essential. It also helps in proper allotment of patients according to expertise in a multi-surgeon setup, where surgeons with expertise will get cases like small pupils, brunescent, or mature cataracts. And for the surgeon also, it helps in selecting the proper procedure, like whether to go for MSICS or phaco, depending on his limitations, for a case with old age, brunescent, and endothelial dystrophy. Also, it helps in ruling out any infective focus predisposing to endophthalmitis. Now, the important thing about getting good visual outcomes is, of course, accurate biometry. The biometry is wrong. Even with a good surgery, you'll never be able to achieve good visual outcomes. So a proper selection of biometry modality, depending on the cataract density, whether we go for optical or immersion ultrasound, it is very important. Also to calibrate the equipment every day at recommended frequency, like the optical biometry and ultrasound every day, and other instruments like the Varion on their regular basis. To have a trained staff, preferably a team, for consistent outcomes, so that they are also developing their expertise and we can have reliable outcomes. Ensuring proper measurements, selecting the appropriate modes wherever applicable, like in post-LASIK cases for post-refractive surgeries and in silicone oil-filled globes. The biometrists or ophthalmologists, if they are measuring it, should always apply the holiday criteria for verification of biometry. The biometry should be done for both eyes, and if there's an axial length difference of more than 0.3 millimeters, which translates to 1 diopter roughly, less than 20 mm, which is a short eye, or more than 26 mm, which is a myopic eye, or if the average K difference is more than 1 diopter between 2 eyes, which again translates to a difference of 1 diopter, or if it is flat, less than 40 diopters, or steep, more than 48 diopters, or if the astigmatism in any eye is more than 3 diopters, then it should be repeated. And again, if the difference in IOL power is more than 1 diopter between the 2 eyes, the biometry should be repeated with a different modality and preferably with another biometrist. Again, selecting the appropriate residual anticipated refraction is also very important. We would like to have a slight minimal myopia of minus 0.1 or minus 0.2 in the normal monofocal cases or even for some EDOFs. But for multifocals, it is better to have the residual closest to 0. Also, to undercorrect the with-the-rule astigmatism in patients with toric IOLs when by 0.25 cylinder. Also, to select the appropriate formula and constants. So, optical constants if the entire biometry has been done on the optical biometer. Personalized A constants if it is possible to refine our results. Also, the latest formula like the Barrett suit, like universal 2 for almost all axial lens, the true K for post-LASIK cases, and toric true K for toric IOLs. Nowadays, KN is, for example, KN is recommended for extreme axial lens. And finally, we have artificial intelligence coming in with the Hill RBF. There are challenging cases like post-refractive surgery or cases with posterior cephaloma where you can get a lot of varying readings. So in these cases, it is always good to have a consultation for expert opinion from a biometrist to an ophthalmologist, or if it is by an ophthalmologist with his peers. Also, using the appropriate updated online calculators for special cases, toric IOLs is very important. And whenever we are transcribing from one machine to another or from toric sheets or into toric sheets online, there should be a clear transcription and clear documentation, and we should always be constantly monitoring and refining. The surgery advice should also be appropriate for on the decision. The appropriate decision should be done on which eye is to be operated. The selection and advice of appropriate IOL types depending on the patient's needs and expectations, and to explain the appropriate visual prognosis to the patient. Ensuring quality surgery starts with ensuring proper sterilization disinfection protocols. So there should be a monitoring and documentation of all the chemical and biological indicators having changed. Regular calibration of the sterilization equipment which we are using, be it autoclave or ETO, and a regular calibration of HEPA filter and other environmental factors. Again, ensure use of standard good quality consumables, always from reliable vendors, not changing the brand often, but staying true to a brand which has given good results. Check the quality, especially for clarity, against a white background and a black background for solutions like the balance all solution or the viscoelastics, and preferably have the culture reports for every batch. Ensure that equipment are in good order and have a backup like phaco machines and microscopes. Case allotment as per skills, as we have seen previously. Have a proper surgical plan for complex cases and handling of complications. And of course, this is the backbone, a meticulous surgery with proper wound architecture, a well-sized centered capsular axis, 5 to 5.5 mm in a phaco, 6 to 7 mm in a rhexis, appropriate phaco parameters so that there is no fluctuations in anterior chamber, complete cortical removal, and IOL placement in the bag with 360 degrees of overlap of the capsular axis. It is very good to have a trained assisting team who understand without much of verbal interaction with the patient on table, ensure low rate of complications so that you know that your outcomes are going to be good. In the post-operative protocol, we should ensure a low incidence of post-operative complications, and there should be a standard post-operative protocol, preferably separating the steroids and the antibiotics. Steroids for a 4 to 6 week period and antibiotics not more than 15 days. Effective management of post-operative complications, which would include a standardized protocol for both timing as well as indications for resurgeries. Accurate recording of day one vision is very, very important. Especially check the uncorrected visual acuity and the pinhole. For this, ensure that the distance is correct and ensure that the illumination of the charts is also correct. And if we find a large difference between the uncorrected vision and the pinhole and everything is clear, then we should suspect the biometry and we should repeat the biometry so that we can address this issue at the earliest. In follow-up, be it at 3 weeks, 4 weeks, 1 month, or later, there should be an accurate visual acuity record with the uncorrected visual acuity being recorded, and it is an indicator of the post-operative astigmatism and also how the patient feels without glasses. So with this, we can also calculate the surgical induced astigmatism. We can improve the UCVA by addressing it, and also we can shift to temporal SICS whenever we are doing SICS. An accurate refraction should be done, and spectacle prescription should be given as per the patient's needs, especially at what his working distance is, especially for the near vision, and ensure proper post-operative care so as to ensure low endophthalmitis rates. And this also includes the general instructions that we need to give. So with all this, we come to monitoring the outcomes and refinement. So when we are monitoring the outcomes, the first thing that we monitor is from the refraction, we can get the postoperative spherical equivalent. And this is indicative of our biometry accuracy. And with this, when this is being monitored, a further refinement is possible. The other key performance indicators to further improve quality would be the intraoperative complication rates, postoperative complication rates, endophthalmitis rates, and also the percentage of patients who have obtained an uncorrected and best corrected visual acuity of better than 612. And more importantly, whatever be the volume, it is important to maintain a database so that you can always go back and do an audit or scrutiny. So depending on the volume, manpower, and technological access, we can have simple Excel sheets through which we can filter data, or MS Access, or we can also develop a software for capture and analysis. And with this, the outcome details can be compiled in the database for regular audit and scrutiny. This helps in refining processes like biometry, like if any change in the A constant is needed for a particular IOL, or helps in modifications in surgery, like shifting to temporal SICS for better uncorrected visual acuity and astigmatism management. It also helps in increasing the uptake of toric IOLs in patients undergoing phaco with pre-existing corneal astigmatism. So with all this, we can improve our visual outcomes. So to sum up, good visual outcomes depend on various factors, not only on skilled surgery or premium IOLs. It is all teamwork, and incremental improvement in quality can happen only if outcomes are captured and analyzed for further improvement in the processes. Thank you very much.